My name is Susan Law. I'm the Knowledge Mobilization Lead for Long COVID Web, and delighted that you've joined us today with two excellent speakers again. And today we have two people from the United Kingdom who are working very hard on different aspects of long COVID research and care. So delighted to introduce you to them in a moment. I'm just going to take a few minutes here to do a land acknowledgement and also some introductory remarks about the objectives of this session. So first, we acknowledge that the land on which we live, work, and gather is the traditional, ancestral, and unceded territory of the Indigenous peoples who have stewarded these lands for millennia. Across this vast and diverse expanse now known as Canada, we honor the First Nations, Métis, and Inuit communities who have lived in harmony with this land, water, and sky since time immemorial. We pay our respects to the elders past, present, and emerging, and recognize their enduring connection to the land that sustains us all. As we engage in our activities, conversations, and shared experiences, let us remember the history, culture, and wisdom that shape the unique identity of each Indigenous nation. May we actively strive for reconciliation, understanding, and unity as we continue to learn from the Indigenous peoples and work towards a future of mutual respect, cooperation, and partnership. Thank you. Okay, just a reminder of the purpose of these webinars. Firstly, to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. Secondly, to provide ongoing updates, spotlights on emerging evidence, and scientific information about the activities of our national network. Thirdly, to contribute to reducing and managing misinformation about long COVID. We do have a code of conduct that's you can find the full version in the link at the bottom of this slide, but essentially it says that we value the engagement around the science and its interpretation as well as its application. A commitment to reasoned discourse, as stated in the code of conduct, comes with a responsibility for all of us to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we do welcome any and all questions and comments in this spirit during this session. Your cameras and mics are off, but we do invite you to please post your questions actually in the Q&A section and the link that's on your screen there. You can use the chat to chat amongst yourselves, to ask questions of us on the operations team, or to make comments as we go along. But please post any questions for the speakers in the Q&A, and we'll do our best to address as many as we can in the time that we have. And finally, we do welcome your thoughts about how these sessions could be more helpful to you. So we have a very short survey, and we'll post that in the chat partway through. And here's the QR code, but we'll post this as well. So I want to stop there and hand it over to our speakers. We're going to start with Kim López-Güell, who is a PhD or DPhil candidate, as they say at the University of Oxford. So congratulations on the work to date, Kim, and I will turn it over to you to talk about long COVID phenotypes and subclasses.
Lovely. Thank you so much, Susan. I'm going to share my slides now. All right. Can you see them? Oh, good, lovely. Okay. Hi, everyone. Good afternoon. My name is Kim López. I'm a fourth-year DPhil student at Oxford. I'm a mathematician and physicist by training. I've been working on long COVID specifically for the last 4 years. So I basically use different data sets to study long COVID from different perspectives. So this is what I'm going to talk about today. Phenotypes and subclasses was perhaps the first 2/3 of my DPhil. Lately, I've been doing more genetic and treatment avenues work. But I wanted to talk about this today. I don't think long COVID needs an introduction here, but as you all know, this is a quite complex and heterogeneous condition, which obviously makes it particularly complicated for researchers to study and doctors to diagnose, and then for patient management. It involves several body systems, and being able to properly phenotype it or properly describe it and define it is of particular importance, at least in my area, where I work with like very big data sets, where sometimes long COVID is not explicitly recorded or diagnosed. So I might see a lot of records for symptoms, for conditions, and I need to like make out who exactly has long COVID from there. So understanding what long COVID is of utmost importance. What I'm going to talk today very briefly, I'm going to introduce two studies that happened a few years back that will provide the context of certain choices we did for the third one, which is the one I'm going to explain for the longest time. A little disclaimer is the third study I was involved in, but I was not the lead of, but I'm going to talk about it on behalf of a couple of colleagues that were more involved in it. So this was a project we led from Oxford back in 2022, 2023. We tried to understand how long COVID was recorded in very big data sets across the world, so particularly from Europe, but also from the US and Korea. We also had data sources from Spain, from Norway, from Netherlands, from France, and from Estonia. And I think I'm not missing anyone here. Primary care, secondary care, so hospitals, also claims or registry, so a bit of everything. And the idea was to know a bit better, well, how the symptoms relating to long COVID or post-acute COVID-19 PCC, I might say one or the other, were recorded, and certain descriptions of the populations who were suffering with these symptoms, so age, sex, vaccination, and the usual. This is not particularly relevant perhaps here. All these databases were mapped to a certain common data model that made it easy to work with them, but this is very technical. So we define long COVID using the WHO definition, which you might have heard before. So this was published in October 2021 by the World Health Organization, and they defined long COVID as a group of patients who were infected with SARS-CoV-2 and then developed at least one of a list of 25 symptoms 3 months after infection and lasting at least 2 months without another explanation. So this is how we retrieved people in our databases. And you can check the paper if you want to know more, because we looked at many other demographics and comorbidities and comparisons. But one thing that was very clear, which is what will inform what I'll talk about later, is that symptoms were recorded very differently in all these data sources, and there were major differences in healthcare practices and recording. We suggested that perhaps the definition operationalized as this was a tad too ambiguous for these data sets. What we also looked at for the same 10 databases was if we could study the subgroups of patients, if there was a way in which these 25 symptoms would cluster, if we could do subgroups with them according to like similarities. And we used a method called latent class analysis, which is just in mathematics we say it's a finite mixture model, but it doesn't really matter, to be honest. These are the main findings. You see on the x-axis the 25 symptoms according to the WHO. You see that there's actually 26 because the one most right is the PCC diagnosis. Sometimes you do find a record of long COVID directly put there by the GP or medical practitioner, but it's not recorded everywhere, actually just in 2 of the 7 databases that we had at the end. On the y-axis you have the 7 databases. Each of the 3 rows is one of these subgroups, so it's dividing the people into like 3 subgroups. Several things to note here. When you see like a square with like that's very deep blue, that means that particular symptom is very prevalent. If it's very light, it means it's not. So certain subgroups, certain clusters were repeated across databases, particularly, as you see noted there, anxiety, depression, gastrointestinal pain, abdominal pain, and respiratory fatigue and general pain. These 3 were repeated across, though there was still some heterogeneity, and some of these databases had some clusters that were unique to that particular data source. The second thing is many of these clusters were overlapping, so it did seem like this was a condition of subtypes rather than just different subtypes, different conditions altogether. And all of them were quite different with respect to demographics, and so there seemed to be like quite a distinction for host determinants for these clusters. Lastly, the respiratory fatigue pain one was the one that was most correlated with the diagnostics code, which might just be a reporting feature, not necessarily like a pathological. It might not be like a pathology feature itself. But this definitely also showed us that we only could get these numbers by restricting the definition to like people who had 3 or more symptoms. Otherwise, it was very ambiguous and we couldn't like really get many results. So one thing we definitely saw after all of these was that using data sets with records wasn't great, and that probably was much better to study self-reported symptoms, to actually like use data collected from the patients. And that, as you can see here in the screen, phenotyping PCC with clinical records had like multiple limitations. So this is what we did, learning from this. This third study started in 2024. We used data from UK Biobank, which is a very big genetic biobank that we have in the UK. In 2023, this initiative started this health and well-being questionnaire, which collected data invited all the participants in UK Biobank, which is 500,000, and they were asked questions regarding post-COVID-19 related symptoms, so a list of 44, but also general physical and mental life impact questions, so how they were doing and all of that. And it was also linked to previous COVID-19 infection records. So with all of these, we could actually like design a better study to study several questions that we had at this point. And this is a lot of information. This is like all the study that we did from top to bottom in kind of high level, but I'm happy to talk about this more later. We started with all the patients active in the UK Biobank, but then after getting only the people who actually answered the questionnaire and had COVID-19 records, we had 172K participants. This is all the people we actually looked at for this study. Around 43,000 of them had been previously infected before actually answering the questionnaire, and 128,000 more or less hadn't. So that was our infected and uninfected group. And what we did was compare these groups for these 45 symptoms that were asked in this questionnaire. And we matched them using propensity score, which is just a method to try and like make the two groups as similar as possible with respect to a set of variables that we decided, which were age, sex, BMI, index of multiple deprivation, so socioeconomic status, a lot of comorbidities, so any comorbidity with a prevalence higher than 1% at index, and others. And then when we had these two groups as balanced as possible, we looked at whether these symptoms were more prevalent in one group or the other, so that we could go from 45 symptoms to a way shorter list of like a more refined list of symptoms that were actually, let's say, causally linked to the actual COVID infection. After having that and having a shorter list of perhaps more relevant symptoms to PCC, we clinically divided them into subgroups of interest, and then we studied those subgroups from identifying pathogen-related and host-related determinants. So looking at whether COVID variants, hospitalization, age, sex, many different variables were different across these groups. So these are the results. You see here the list of 44 symptoms. Of this, only 10 were actually clinically relevant, so with an odds ratio of more than 1.05, so actually appeared significantly more in the PCC group compared to the control, and were also statistically significant, so the p-value was with the bump-finaro connection was small enough. So these are the 10 final symptoms. As I said, they are divided into 4 groups. that this is what was done clinically by us. So these 10 were a group that we called ENT, ear, nose, throat, loss of change in sense of smell, loss or change in sense of taste, and hearing loss. A second group of respiratory and chest symptoms, with symptoms of shortness of breath or trouble breathing, postural tachycardia, tightness in the chest and chest pressure heaviness. A third subgroup of neurological symptoms, with symptoms of problems in thinking and communicating. And finally, mild fatigue was its own subgroup of general systemic symptoms. So these were the 4 final subgroups that we found. These were the percentages of the patients that belonged to each of them. As you will see, this adds up to more than 100% because some people belonged to more than one. The most populated subgroup was the general fatigue subtype, then followed by ENT, then the neurological one, and finally the cardiopulmonary subtype was the least common, with only around 10% of the patients belonging there. I'll now talk a bit about the determinants of health. So this is when we looked at how different these final subclasses were with respect to particular variables of interest. So what you're seeing now on screen are pathogen related. So from left to right, it's COVID-19 variants, so the infection variant, whether the patient had one or multiple infections, then hospitalization, whether they were hospitalized for their COVID-19 infection, and then whether they were vaccinated at baseline or not. So none of these will be particularly surprising, I think. For the variants, BCC risk seemed to decrease variance-wise, so the wild variant, and that was generally, as you see, this distribution of these variables was quite similar across subgroups. So the wild variant had a highest BCC risk, then followed by Alpha and Delta, and then Omicron at the end. For infection, being infected multiple times with COVID-19 increases the risk of BCC, according to what we saw. Being hospitalized, so having a more acute infection, also increased the risk of BCC. And finally, vaccination, either a full or then a booster vaccination, lowered the risk of BCC, which again has been seen in other studies, so this is not surprising. This slide is related to host variables, so this is the patients, the affected individuals' characteristics. Again, except from age and sex, for the majority of other variables of interest, the distribution was quite similar across subgroups. For age, we saw that the highest age bracket, so 75 years of age or higher, had a higher risk of BCC, and so did females compared to males. Then healthy lifestyle was protective for BCC, as well as a lower BMI or a lower deprivation index. And for the older comorbidities that appear on screen, most of them affected BCC, particularly COPD, and depression as well for some. And I think the only one that was at some points not significant was chronic kidney disease or coronary heart disease. What definitely varies a lot across subtypes was the impact in health. So this is self-reported. There's about different questions of this questionnaire related to physical and mental function impairments. As you see on screen, these questions range from dealing with people you do not know, getting dressed, doing your day-to-day work, etc. What you're seeing on screen, the numbers are odds ratio, so this is compared to people who had COVID-19 but no subsequent symptoms. What would you see is that to start, even the lowest of these odds ratios is practically 2, so all of these people had some function impairments compared to control group, but it did vary a lot depending on subtype. So for physical function impairments, the most affected subtypes were cardiopulmonary subtype first, then neurological subtype, followed by mild fatigue and then ENT. and fundamental function impairments, the most affected subtypes were neurological subtype first, followed by cardiopulmonary, and then ENT. And then mild fatigue, and then ENT. And what is also very, very startling is that belonging to more than one subtype greatly increases the effect on daily life, on all these impairments, by at some points multiplicating the odds ratio by 3 for each of them. So being only part of one subtype already has a big impact on daily life, but having 2 might triple it, and so on and so forth. So some conclusions from the studies that we did. Different data might need different definitions. What I mean here is that, particularly when you work with data like I do, so not when you do an RCT, when you're actually following patients, but you work with retrospectively with data, you need to take into account how the data you are working with is. And sometimes you might have to operationalize long COVID as definition differently, depending on what you have. Second, patient-reported data sets are much better suited to study BCC than clinical records, for sure. And finally, these we've seen, but many other people have seen as well, BCC has quite different presentations. It has very different clinical manifestations, subclasses and subgroups that are definitely clinically meaningful. And going forward, not only for characterizing, but then to study other things of interest. I think I saw lately there was a report on what the patients want more, and it was basically biomarkers or treatment avenues, which is understandable. We probably will have to assess that, also taking into account subgroups and not treating these as one only condition. And this is all I had prepared for today. These are, you see here the QR codes. These are the links to the 3 papers that I've been talking about. As I said, we've been doing work after these, mostly on genetic determinants and some treatment avenues, though that will be published soon. But I did want to talk about particularly this third study today. Very happy to take any questions now, or please do drop an email for any other thing you want to know. Thank you.
That's terrific. Thank you very much, Kim. That's maybe you could leave that slide there for a moment, just so people can gather the information from the QR codes. That's terrific. I just wanted to follow up. You skipped over your second point there about patient-reported data sets are sort of preferable. Can you just talk about how prevalent they are in research, or where they are in terms of their development and use?
In the area I work in, which is with, I work a lot with EHR to be fair, but they're not very common. We do have, particular for long COVID, we have the UK Biobank in the UK, but I know of none other data set that you can acquire like this, except if you actually can follow your own patients and create your own surveys, which is not that common either. So,
okay, thank you. So we have a question from one of our patients, colleagues with Lorraine. What would you like to see doctors do differently when noting long COVID symptoms? Any suggestions for a form they could use, for instance? And how can physicians use this information in their practices?
I think not only for long COVID, but generally for anything. As someone who works with the data that GPs actually introduce in the UK in their system, as long as they actually introduce the data as they should, I'll be happy. Sometimes what happens is that not everything is introduced, or everything's introduced as text instead of actually putting the records, and that severely limits the research we can do. So if a symptom is repeated, introduce it another time so that we actually know that it's happening again. So trying to think that what you're writing is going to be looked by a researcher and not just yourself looking at your if you already know the patient. I think that's helpful. That's the main thing I would ask practitioners to do as someone who uses data.
Okay, thank you. I'm just wondering if Professor Emma Wall, do you have any questions or any comments on Kim's work here?
No, it's really interesting. And I think actually some of the questions will get answered by our presentation, because I'm presenting from a different perspective, which is from the specialist long COVID clinical service. And UK Biobank is an amazing resource, but it is limited by the data that goes into it and by the people who sign up for it. So we know that people from traditionally deprived communities and ethnically minoritized communities are much less likely to sign up to UK Biobank and give samples and data and link records. And so I think it's really brilliant that it's a resource that we can look at. But like all resources, we have to look at them all together in context and work out who's doing what. And I'm going to talk a bit about how we collect data prospectively in the clinic and how that has led to some really interesting findings.
Okay, terrific.
100%. Super important. One of the big limitations of UK Biobank is the very restricted cohort that we have. So it's a lot of old people, a lot of like a white background, particularly like economically wealthy. So it's like a very, particular cohort that we can follow. The best thing about retrospective studies is that we tend to have very big numbers, but then we have a lot of limitations that prospective studies don't have. The UK right now is launching a new initiative where they're collecting data from a much more representative cohort and also collecting genetic data. So we will replicate this study there, but that hasn't been possible at the moment yet. But that's a very good point, and so I'm happy that you made it. Thank you.
Okay, thanks. We have another question that just popped up. How should a patient with long COVID navigate the healthcare system to access long COVID treatment when meeting with a primary care physician who has no specific knowledge or resources to share with the patient? So perhaps you can answer that from the perspective of thinking about how to describe symptoms or how the patient can interact with a physician to work on what are the treatable issues. Yeah.
I'm sure Emma is much more like she'll be much better to like answer this question than me. But I've worked with some other people who are in specialized long COVID clinics, and I think the best thing you can do is talk to your GP. Tell if you really think you've got long COVID, like be particularly convinced, and then actually try to get referred, because the best care you'll get is probably there. I don't know if Emma, you want to add something. You are an actual practitioner, so you'll know better than I do.
Yeah, so we know that many of our patients really struggle to get to our service and get referred, and it's a real battle in lots of places. And part of that is reluctance on the part of primary care practitioners to mute a diagnosis of long COVID and then make a referral. And often there's lots of barriers put in their place in the way for that to happen. And so one of the reasons I come and do these webinars is hopefully lots of primary care practitioners are listening. And I'm doing one at the British Medical Association next week deliberately to try and highlight to primary care practitioners that this is a real disease, it's biologically relevant, that patients experience significant degree of barriers that we've published on. I'm going to show some of that data, and that actually what we need to do to get people the healthcare they need is believe them and listen to them, and then make sure the referral pathways in place to move them forward. And I say to patients, many of whom email me and say, how do I get referred? I say, here's our website for our clinic, and show your GP what we do, and say, can you find either a local service that's similar or refer to us?
That's a terrific answer. Thank you. And I note that there's a comment about, can we share this particular slide on our website and social media? Very happy to do that. And Lorraine has also shared the list that we have of useful resources that are evidence-based for patients and clinicians actually as well, and researchers. So, okay, thank you. I think that's terrific. Thank you so much, Kim. We will be posting your slides and your presentation on our website. And we do know that lots of people actually have a look afterwards when they have more time or on their time as well. So we'll switch over to Professor Emma Wall. Thank you for joining us today. Professor Wall is a clinical professor of infectious disease at the Queen Mary University of London in the UK. And she's going to talk to us about the largest clinical trial on long COVID and the importance of holistic clinical care and management of treatable traits. So over to you, Professor Wall. Thanks.
Okay, thanks so much, Susan, and thanks. If anyone needs to ask me to interrupt, to stop, slow down, I'm very aware I talk fast, and I'm doing my best to talk slowly, but it's a challenge for me. So hopefully I'm going to move forward my slides. First thing to say is I have no conflicts of interest to declare, and I'm not presenting data at the moment, unfortunately, results from the trial, because those manuscripts are currently now accepted for publication, but not in the public domain yet, but they expect them to be soon. So I think the most interesting thing about long COVID is it's a disease that was defined by patients. So I'm just going to put my laser pointer on so you can see. And this is a really interesting paper, which is looking social media mentions in the thousands of long COVID and this term long COVID. And the first mention is in March 2019. Sorry, March 2020 here, tiny little flip. And then as you come forward to July 2020, suddenly 3 months after the pandemic certainly hit the UK, that's when people on social media start saying, look, I'm not getting better, this is a problem, and coining this term long COVID. And interestingly, this is all driven by Twitter in the blue rather than other platforms, where it was picked up later on by Reddit as well. So long COVID is common. In the UK, it's estimated that 2 million people have been affected by some form of sequelae which have met the WHO or UK definitions. We know that it's a multi-system disease and that clinical presentation is heterogeneous. And we know that approximately 30% of people affected have chronic disabling symptoms. We also, recent data has shown quite how expensive long COVID is, and the lack of research, particularly in the UK and in other places, and the lack of provision of adequate healthcare resources to manage people with long COVID has had enormous expensive costs. So in the last 5 years, £24 billion hit to the UK economy. And a recent report from the OECD, of which Canada is a member as well as the UK, that predicts that if we don't manage long COVID better and treat people better, there's going to be a 0.1 to 0.2% reduction across the OECD in GDP. And that translates to an estimated $135 billion, or the entire healthcare cost of the Netherlands. So it's a big, big, big expensive problem. And the more policymakers and clinicians ignore it, the bigger the problem mounts. Also, we know that long COVID is biologically unresolved, and that's something that I'm working hard on along with colleagues. And we know at the moment there's no evidence base for diagnostics or disease modifying treatments, unfortunately. So in the UK, there was a really great start to long COVID care. And actually in 2021, my colleagues published the first NICE guidelines. NICE is our National Institute for Clinical Excellence and provides guidelines on a number of diseases. And the NHR dedicated a £50 million research funding resource, of which we were a fortunate recipient. NHS England established 90 specialist centrally funded clinics in 2022 across the UK. The model of these clinical cares varied. But unfortunately in 2024, funding transitioned to local funding boards, so it is no longer centrally mandated these clinics are funded. And currently, because of competing funding priorities across the UK, only 34 clinics nationally remain in operation in 2025, and we have no idea how many in 2026 yet. There's no standard model of clinical service, and there's been this vicious cycle of underreporting and coding in primary care. And as Kim highlighted, you need those codes to be able to pull out who's got what disease, how many people are there affected, what proportion of the UK, what are the demographics of those people. So if you don't code in primary care, then that data can't be pulled out. So when it's underreported, particularly in primary care, and not coded, then you end this vicious cycle, which then leads to this false narrative that there's actually no disease out there, which we know is not true. So usual care, this is the commissioning guidance in the NHS. And essentially there's a holistic pathway which is recommended across long COVID clinics. So at all stages of this pathway, people are recommended to code for the disease. So it's coded in NHS records, whether that is in primary or secondary care, offering self-management guidance, primary care access to wider community peer support, social prescribing, vocational rehabilitation, therapy if required, wellbeing psychological therapies, all dependent on the needs of the individuals. And there's a pathway where the gatekeeper is a general practitioner, referring people on either for alternative pathology or specialist assessment. And when you get here to the multi-specialty service, there's an initial contact for triage, prioritisation, and that's currently our nurse consultant, Florence, who's in Marvel in our clinic. And then there's a clinical review, and then there's a plan for either specialist input or ongoing community-based rehab, and where people are able, we're able to discharge them. The principles of care is that it should be personalised, it should be supported by a multidisciplinary team, there should be access to rehabilitation, and particularly enabling self-care, including digital supported self-rehabilitation. But there is no evidence for any of this. And when we look back over the numbers of people who are being seen in specialist clinics over the UK, this is monthly clinic data from April 2022 to July 24 across this network of 90 clinics before they shut. Actually, the follow-up rate was remarkably consistent, and lots of people were not being discharged or not able to be discharged. And originally the clinics were designed as a one-stop shop, see, appropriately manage and discharge, and there's a large proportion of patients who we can't discharge, they continue to need our care. So this is the UCH long COVID clinic, which started in a van in May 2020 by the visionary Melissa Heitman, here in the middle of our clinic. And over the last now 6 years, we have been managing over 7,000 people. Melissa has become the national clinical lead for long COVID and NHS England before it was recently disbanded by the current administration. She helped write the guidelines. We've supported 15 plus research studies out of the clinic and really believe in research that's embedded in a clinical service and led by patients or co-led by patients. We work closely with charities and community teams, and we undertake advocacy for patients and services. So I'm on this webinar as part of that. On our website, we have a number of webinars and support videos that patients can access anytime. So we were really struck by our patients in 2020, and we hadn't at that point really thought about tracking their symptoms, although the Trust, our hospital, had just adopted Epic. And this paper was in preprint in 2020, published in 2021 by Hannah Davis and the Patient-Led Research Collaborative. And it really struck a chord with us because the patient reported symptoms in that paper across the US were really what we were seeing in our patients. So fatigue, predominantly systemic symptom across nearly everybody, and a really high rate of post-exertional malaise. And what was also really striking about Hannah and her team's work is that when you look over time, lots of other symptoms, those systemic symptoms over time get better, but the fatigue and the post-exertional malaise do not get better. And this really helped underpin our understanding both to design tools within our clinical service using Epic, where we can systematically collect routine data from patients at every visit about their symptom burden, particularly using scores that we can track. But also that when we were thinking about our clinical trial, we decided to power it on fatigue because it was clear that fatigue and post-exertional malaise don't get better on their own in this cohort, and they need to be modified. So we've gone back recently, this was just published in January this year, and looked back at all the systematic symptom we've been collecting in 5,000 patients from the clinic between 2020 and 2024. We define recovery as when someone reaches 75% or more of their self-reported best health. And this graph here looks at the ratio for recovery from long COVID. So if you've got an arrow going to the right here, then this factor on here, one of these factors, means you're more likely to recover. So interesting, the strongest predictor of recovery is vaccine before having the onset of long COVID, but interestingly after. So if these lines don't cross the dotted line, then that means this is significant. This is a robust finding. But similarly, if you look on the other direction, non-recovery, it won't surprise any of the audience here to hear that the three factors which predict non-recovery are fatigue, postural malaise, and myalgia, so post-exertional malaise and POTS. And this is really chimes with Hannah's data. So when we went into our trial, we did pick the right symptoms to try to modify. When we track the FAS, the fatigue score, I'm going to talk about that in a minute and why we chose that. And we stratify that out from no fatigue to really very severe debilitating fatigue and look at time and the proportion who don't get better, we can't discharge, that overall, people who present without severe fatigue, we are able to discharge the majority of them over time. Slowly, but they do. But the people with the most severe fatigue do not get discharged. They remain under service. They're not getting better. And those, again, are the people we need to modify. So we also went back and looked at the demographics of these features. And similarly to Kim, we split them up into post-hospital, because a big teaching hospital, we see a lot of people, nearly 1,000 of our patients were after admission to hospital, and 2,600 here were non-hospitalized. Unsurprisingly, the hospitalized cohort were older and had an equivalent male-female gender, slight male bias. But what was really striking is that at the first assessment, although the number of symptoms was the same, The best health proportion was much lower in the non-hospitalized cohort. The EQ5D was lower. The chances of being recovered were much lower. The symptom duration was longer, and the fatigue score was higher. So actually our non-hospitalized cohort were more sick than our hospitalized cohort. And we've now discharged most of our hospitalized cohort. We don't see hospitalized patients anymore, but we do see an ongoing burden of non-hospitalized adults who've had a community, often mild infection, but don't get better. One of the things we did was start observing that why our patients had post-exertional malaise. And my colleague Toby Hillman started walking patients up and down just the corridor outside outpatients clinic and doing a capillary blood test, just with pricking in the ear so he could do a blood gas analysis. And what he found was about 20% of the people who had an abnormal exercise test, they couldn't complete the short walk up and down the corridor. And he was looking for stickiness in their blood. And there was a much higher ratio of people who had an abnormal test who couldn't complete their exercise, who had sticky blood. So we worked with Marie Scully and her lab to try and understand this. And what I'm showing you here is a control or people with post-COVID syndrome. And this is blood just put over a collagen flow chamber. And we saw that the collagen flow chamber was covered by in 55% of people with long COVID versus only 16% of the blood stuck in the control. So it was sticking. It was very sticky. It stuck to the collagen. When we put in a binder to stop something called von Willebrand factor binding, we saw that the coverage went down across the board, but it remained high in people with long COVID. And when we added the von Willebrand factor back in, it was equivalent. So this is a sticky blood that is mediated by von Willebrand factor, suggesting that the endothelium, the lining of the blood vessels, is inflamed. So all of this data fed into our giant clinical trial, Stimulate ICP. And the trial had three components because we thought it was very unlikely there would be another large funding call. So we wanted to try and squeeze as much into our research program as possible, which has its pros and cons, as any researcher on the call will understand. But we wanted to look at what was current care across the UK. We wanted to look at inequalities and long-term conditions and how similar was long COVID to other long-term conditions in terms of deprivation, healthcare usage, symptoms and recovery. And in the middle, we had this complicated trial that I'm going to divide up and talk about a bit more. But when you're designing a trial, you have to think, well, what is your patient-reported outcome? What outcome do you want to use? We didn't have a biomarker. We didn't have an easy blood test that we could use to say, right, you're better or not. And at that time, and still now, there's no agreed patient-reported outcome. So Melissa and Toby, my colleagues, they're respiratory physicians. They look after a lot of people with a disease called sarcoidosis. And that's often felt to be a similar post-infection condition. And sarcoid has the FAS associated with it. So it's a 10-point questionnaire, so it's easy to do. It's well validated in respiratory disease. It's robust and reproducible. And it captures physical, mental, and post-exertional malaise. And we know crucially what a minimally important clinical change is, which is a 10% change in the FAS. We know that's clinically meaningful, and that's crucial when you're designing a trial. We also, as a secondary outcome, used a visual analog scale because the EQ5D is a measure of quality of life, but it's a long and cumbersome questionnaire that's designed for health economics. And when we talked to our patient representatives about it, they were no way going to be able to complete it. So this instead is a visual scale which says 100 is your best health imaginable and 0 is the worst health. And we know that 75% or more means clinically meaningful recovery. And patients can put a cross and slide up and down depending on how they feel. So this is something else we're easily able to track. Into our giant trial, we wanted to evaluate the whole clinical care pathway. So before patients came to see us in clinic, they were randomized at a primary care network level. So they didn't know they were being randomized to getting a whole body MRI or a cover scan MRI or not. And this was based on some data from cover scan that looked at this whole body quick 20-minute scanning approach to see whether there was evidence of impairment as defined by the cover scan inventors perspective in any particular organ. And overall, they were able to publish that people long COVID follow-up cohort had a number of organs that were impaired, and that was statistically greater than the healthy recovered adults. The other bit we did was in the cluster trial was look at for digital rehabilitation, and this was using an app that had been co-designed for other diseases with clinicians, and it contains symptom-based information, questionnaires, a message dashboard, and there was lots of widespread adoption across long COVID services. So we knew lots of clinics were already using this app, and we wanted to find out whether it was useful or not. So this is how the trial worked. people at the primary care level. So it wasn't randomized by the referring primary care provider, but by the network. So if they lived in a particular area, and that was controlled for deprivation indices and urban versus rural geography. People were either randomized into a group where they did get an MRI before coming to clinic, or they in two groups, and two groups did not. And then those groups were subset out by whether they were going to get randomized to the app rehabilitation tool or not. So when they came to clinic, they were formally recruited into the trial, and we obtained consent to use their MRI data. And they were also offered recruitment at that point into the nested drug trial. And then at that point, everybody received rehabilitation, advice from a specialist physiotherapist, and then two groups also received access to the app and training and onboarding. And then at 12 weeks, we collected data on the primary endpoint for all of those groups, for the FAS and the EQ5D, amongst other questionnaires. And then we conducted a 24-week endpoint after app usage had ceased, and collected data across from everybody. And then those data were all analysed across 6 sites where we were able to roll out the MRI scan. I mentioned a nested drug trial, and this was an open label RCT that was initially eligible for everybody coming through the cluster trial. You had to have a clinician-based diagnosis of long COVID. Everyone was equally randomized to either get rivaroxaban, 10 milligrams for that sticky blood, colchicine, 500 micrograms BD, famotidine with loratadine as a dual H1/H2 antagonist, or usual care, no drug. And I can happily chat afterwards about the rationale for selecting those drugs and those doses, but I'm not going to go into that in a lot of detail. And the paper is about to be published, which does cover that in a lot of detail. Our primary outcome for all of the trial was FAS at 3 months, and EQ5D VAS at 3 and 6 months. Our power calculation originally estimated we needed 200 participants in each arm to detect a change of more than 3 points, or approximately 10% of the minimally important change. What was interesting about doing the trial in the midst of COVID and all of the changes in the NHS is that we originally designed it to be nested in this nice pathway, so we would be able to report on all aspects of a clinical pathway relating to rehabilitation and investigations. I don't know why, sorry, my screen's making funny beeping noises. I'm sorry about that. The eligibility was originally restricted to new referrals, but by 2023, we were below target for our recruitment. So we expanded to 6 new drug-only sites. And that was also because our patient participants who had been in the clinical service for some time, so hadn't been eligible for that pathway bit of the trial, were very upset that they couldn't be included in the drug trial, completely reasonably. Sorry, I don't know what's happening to my screen. It's just somehow misbehaving. Can you still see my slides?
No, we can't actually.
Okay, I'm going to stop sharing a second. I don't know quite what's happened there. Sorry. Let me go back in. That was very odd because my screen was earlier trying to send you random messages, and I don't know why that is either. I'm sorry about that. If I'm producing random messages in the chat, then I apologize for that.
We don't see any messages, so that seems to be working.
I can hear a funny beeping noise. Anyway, I'll whiz through the rest of this. So then we then had 12 sites. So we had to control in all of our analyses for the original cluster allocation and the time since symptom onset, because they weren't new referred patients anymore. And we had to generate time-matched usual care comparisons to the drug arm. So it's been complicated, the analysis, and that's why it's taken some time. So far, unfortunately, I can't present the trial outputs because they're not yet published, but we have produced a number of other papers which are all looking at lots of aspects of clinical care for meet our work package 1 and our work package 3 about health inequalities, big data, the clinical data I've just shown you, symptoms of mental health, experiences of stigma, patient perspectives of accessing care. And what I would say is all of these papers are open access and available on our website. And I really want to highlight this tool that was developed by my colleague Nisreen Alwan as part of the trial, which is for supporting patients at home, and particularly it's how to support people with lived experience who are struggling to articulate their symptoms or disease to their patients, to their family, their friends, and their healthcare practitioners. And so there's some tools there to help prompt how to have effective discussions, particularly with your GP, and get referred if you're able. So a summary of our findings from those broader pieces that I didn't go through in detail today is that, unsurprising to this audience, people living with long COVID experience substantial stigma and barriers to effective care. This means that the long COVID is underreported in coding data. NHS care for people with long COVID is fragmented now and dependent on local funding. But we've shown clearly that specialist clinics reduce healthcare costs for people with long COVID. So we're keen to continue to advocate for specialist management. We found that symptom severity is greatest in our non-hospitalized adults, and that the most common symptoms are fatigue, breathlessness, and brain fog, and the factors which predict your recovery trajectory may be modified by vaccination. Our ICP drug trial were completed and impressed. Hopefully will be published in the next few weeks, and please do look out for them. And I want to place one final shout out for the International Post-COVID Post-Infections Conditions Society, which is a British group of clinicians, rehab specialists, physiotherapists, and all-round brilliant people who hold an annual meeting and also do webinars, and would be really great to interact with and support and potentially do co-initiatives with. So please do consider joining IPIC or talking to IPIC about co-produced events. That would be really brilliant. So I'm going to end there and thank Ami Banerjee and Mel Heitman, who led the trial, between them and the whole of the Stimulate platform, and a huge number of people to thank, but particularly to want to pay thanks to our patient team, who really have been totally brilliant in advising us, and all our support groups, and particularly the late and sadly missed Ondine Sherwood, who is a huge advocate for us. And instead of showing you a list of names, I'm going to show you a list of smiley faces. Here's Onadine, who sadly died not of long COVID during the course of the study, and all our colleagues, friends, partners, and everyone who helped support the study. And I'm going to end there. And there are our patients on one of our Zoom, our patient advisors on one of our Zooms. Thank you.
Just terrific, Emma. Thank you very much. That's excellent overview of all of the really important work you're doing. So thank you. We have had a request that we post some of the material from both of your presentations now, so we can certainly do that within our list of resources, but also we can do a little feature in our newsletter as well. So that's super helpful. Thank you. There's one comment in the chat I'll just draw your attention to from Kim. I believe that the code for long COVID expires after 1 or 2 years. So if you're a patient in the UK tuning in to do ask your GP to ensure it's on your record and hasn't expired. Is that true?
Oh, it's Kim. Hi, Kim. I don't think that's true, Kim. It's not that I'm aware of. I think only a clinician has to take it off your record once you've been coded for it, but something we can chat about another time, and we can definitely look into.
Okay, that's helpful. Great. Someone is curious about whether any US institutions have approached you to speak and share what you're doing to the US market.
So that's a great question. I did present the trial data in Boston at a US meeting that was mostly around the Recover initiative, but I haven't engaged with many patient-led initiatives or clinician-led initiatives in the US, but I'd be very happy to do that.
Okay, that's great. Thank you. Kim, I'm wondering if you had any comments on Emma's presentation.
Emma, what a lovely presentation. Really, really interesting. I could ask so many things. One thing that comes to mind is, for me, it's very hard to do research on people who might have been infected with COVID recently, because we don't test nationally like we used to, right? I wonder if you see in your clinic people who are still developing long COVID these years, 2026, 2025, and whether they might look very different from people who might have had this condition for longer.
So we're definitely seeing less people present with anosmia and other ENT symptoms. Definitely that has really melted away. But we are still seeing people present with fatigue, post-exertional malaise, breathlessness. And many of our patients actually have been ill for a long time and struggling to get to our service and have finally made it. We are seeing new referrals and new people who've been ill in the last 6 months. But you're right, it's very hard to pick apart. And one of the things I think we're moving towards a model where actually it's a symptom-based post-infection model rather than a specific, this is definitely long COVID, because we don't really have distinguishers now. And there are people who with lived experience of other post-infection conditions, and particularly ME/CFS, who have many overlapping symptom phenotypes. And so I see very much long COVID as a good way in to understand the biology of all of those conditions, because we know what caused the long COVID in our long COVID cohort. And so pulling apart that biology means that we can then test if that biology is applicable and which components of it may or may not be applicable to people with other post-infection conditions.
That's terrific. Thank you. I know that Angela Chung has joined, who's our nominated principal investigator for the Long COVID Web Network in Canada. Angela, over to you if you have any questions or comments.
Emma, thank you for like a great presentation about Stimulate ICP and the work that the UK is doing. So in Canada, we're always looking at the UK and thinking, why can't we do this in Canada, right? So I do have a question. I run a clinic in Toronto as well. I do see people recover. So the data that Kim presented and what you were talking about was like people with fatigue and post-exertional malaise have a harder time recovering. So do you see people recovering? Because I'm seeing people recovering, and who out of that crowd with fatigue and post-exertional malaise recover?
So that's a really great question. We do see people recover. I had my favorite phone call ever was when I phoned up a patient and said, and the husband answered the phone, and I said, where is Mrs. So-and-so? They said, oh, she's climbing Mount Kilimanjaro. And I was like, wow, you're definitely better if you're going to climb a mountain, a big, big, big mountain in Africa. We do see people recover. Unfortunately, in our experience, by the time they made it to our specialist service, those people are probably in a minority. But I love it when my patients get better. And one of the things we're trying to do with that analysis was work out what predictors. The only consistent predictor came out was vaccination. And I do think that trials of vaccination would be useful in this space. You'll see from our trial when it's published that essentially it won't be news to you to hear that a combination of really good supportive care with good pacing plus or minus drug at that point. There's no point giving a drug just out willy-nilly. The drug has to be in the context of the good supportive care where you address someone's treatable traits and all their physical and mental health challenges, and then add disease-modifying drug in there. Then you're going to see your best effect. We're really excited when the results of STIM come out properly and we can have a broader discussion about best management for people with long COVID.
Great, thank you. Yeah. I don't think I have anyone climbing Kilimanjaro, but I have people going back to running marathons. And they were unhappy because they can't make the time that they used to.
Yeah.
But they are definitely a lot better. They couldn't walk a block without being short of breath prior. So yeah.
So I think those people are really important to study, aren't they? To understand how do they got better? What was it? What changed in their biology? And certainly, in my experience, the really good, really good pacing is the key to getting better and minimizing your post-exertional malaise crashes. And that's where people really start to turn the corner. And I had a patient I discharged, she was bedbound 3 months ago because she had engaged with a really specialist physio and had been really strict with her pacing and then had managed to make a recovery. And so this idea that you've got ongoing damage, tissue damage, every time you're overexerting yourself. And I do feel strongly that one of the reasons we see so many middle-aged women with long COVID is because they're the group who are least able to actually rest and recover. When you're chasing a job, chasing children, chasing people to feed, walking the dog, that's the hardest time of your life where you to actually really stop and pace. And so I'm sure that that's a component of it, but I don't know.
Sure. Yeah, that's what we see as well. And I'm just going to bring out a question in the chat about have you linked genetic testing to long COVID phenotype clinically?
Not yet, no. And I've been talking to Hannah Ollier, who leads the Host Genetics Initiative. She published the long COVID GWAS last year in Nature Genetics. And she's extending lots of her work into UK Biobank at the moment to try and tease apart the genetics. There's also a big UK study in Edinburgh, Decode ME, which is looking at ME-CFS and the genetics of that. And essentially, Hannah and her team are looking at shared architecture of post-infection conditions. So I don't know if we're quite in a place yet where we can generate a polygenic risk score that is robust enough to go into clinical use. But if you're reviewing my latest grant that went into the Horizon scheme where we proposed doing exactly that with her, then please give it a favourable opinion and we can make progress in that space.
Great. Thank you so much. And I just want to thank Emma and Kim for presenting. I think the Long COVID Web Canadian Research Network really can benefit from everything that you have done and learned. So thank you. Back to you, Susan.
Okay, great. Yeah, thank you. I think we'll do one more question because we're at time, but it's pertinent to your just most recent comments there, Emma. What do you think of the move to integrate research in all conditions similar to long COVID? And I noticed that it's post-COVID and post-infectious conditions. This would then include post-chemo symptoms, Sjogren's, if I pronounced that correctly, and other conditions. Yeah.
So I think it's really important. I think we're learning a lot in that space. And I think for example, a rheumatologist colleague told me that even in 50% of people with severe rheumatoid arthritis, when you biologically manage their inflammation, only 50% go back to work because they're too fatigued. And understanding why people get fatigue after inflammation more generally and how we can best understand the biology and manage that, I think is going to be a really exciting field in the next 10 to 15 years. And I think certainly bringing together the learning from long COVID into other conditions where we can really unpick that and not just minimize people's fatigue, because as doctors we like to say, oh, well, biologically we've made you better. Your tests look great. And the person says, well, I can't go back to work. And we're not so good at that bit. And so the model that we've certainly set up in the UK for this holistic service that reaches out into the community, and we link up with our community teams and we provide really good ongoing holistic care. I think that model of care will work well in lots of other conditions.
That's terrific. I think we'll have to end it there, but thank you so much. Really appreciate both of your presentations and all the work that you're doing now and continuing to do. So thank you in advance. Terrific.
No worries. Look out for the paper, hopefully soon.
That's right. Have a lovely evening wherever you are. Thank you.
Bye.
Bye-bye now.